So we have a couple of committee members who can't make it. Oh, okay, it's 9. It's 9 a.m. Thank you for joining us. It is August the 16th, 2024. Welcome to our Metrics and Scoring Committee meeting. Summer's slipping away, but nonetheless, we have a lot of work to do. I remember when moving to Oregon, I noticed that a lot of people took August off, at least in the Willamette Valley, because of the nice weather. There were a lot of canceled meetings in August, but not us. We got some work to do here, and looking forward to our meeting. Thank you for joining us. Do we have everyone in our committee join? As I look at our grid, that sometimes doesn't tell me the full picture.
It doesn't look like we have everyone yet.
Okay, so we have, thank you for your patience in these few seconds and first minute or so as our committee and colleagues across the state join us and find their way in the internet highways and cameras and so forth and phone systems. They're welcome into our meeting. Two committee members have notified us that unfortunately they will not be able to join us. But we do have 7 of us in quorum, and that happens as our commitments take us away from this venue. Okay, how are we doing now, Allison?
I see more committee members, so I could start with a roll call if that sounds okay with you.
Okay, hopefully we will catch up. Please do. Thank you.
All right, I will start with you, Jorge.
Present. Good morning, everyone.
How about Manu?
Good morning, present. I'm finishing up breakfast, so I'll be on camera in the next 5 minutes.
Thanks, Manu. How about Leona?
Good morning, I'm present.
Good morning. Lourdes?
Morning, present.
Good morning. Stephanie Fitzpatrick?
Present. Good morning.
Good morning. Courtney Whitten Rivera?
Good morning, present.
Good morning. Hidea Setu? Looks like maybe no Hidea yet. I can check again with her. And I do know that both Silver Marquez and Shamiko Montgomery send their regrets. They're unable to join us today. I'll just check one more time. Hidea, are you there? All right, that seems like a no. And then just for the record, I will note for OHA staff, we have myself, Allison Proud, and I am also joined by Ashley Walshley, Stacy Schubert, Derek Ranke, Katie Howard, Curly Castaneda, Gladys Rivera, Erin McCauley, Lisa Bowie. There may be more, but that is everyone I can see right now.
Thank you, colleagues, for all the hard work you do at analytics, including managing this quality incentive program and a lot more that you do. Thank you so much. So our main objectives today are to finalize our draft challenge poll. We drafted that in July, and we are going to vote for the final version of it. And then we are going to start drafting our benchmarks for the 2025 measure set. As you know, that is the second most important activity of this Metrics and Scoring Committee, setting, assigning improvement targets for annual progress in these measures based on the combination of benchmarks and improvement target floors. Let's get started with the business aspects of our meeting. In our packet, you received the July draft meeting minutes. I wonder if we have any questions or comments. July draft meeting minutes. Otherwise, I would welcome a motion to approve those minutes.
I'll motion to approve.
Thank you. Any seconds?
Yeah, I second.
So we have a motion to approve from Leon and a second, I believe, from Manu. Could we do a roll call vote, please?
Yes, and I believe Hidea has joined now, so we'll start with you. Hidea, are you there?
Yes, can you hear me?
Yes.
Yeah, here.
All right, do you vote yes on the motion to approve the July minutes and acknowledge the consent agenda?
Yes, I do.
All right, Lourdes,
Approve.
Manu,
Approve and acknowledge.
Leona,
Approve and acknowledge.
Stephanie,
Approve.
Courtney,
I acknowledge the consent agenda and abstain from the minutes as I was absent.
and Jorge.
Acknowledge the agenda and approve the minutes.
All right, that is unanimous amongst the committee members that are present.
Thank you. Thank you, everyone. Next, we have a couple of business and committee business announcements from Allison.
Yeah, so it's hard to believe we're at this time again, but next month you are going to be voting for your new chair and vice chair. This will be for a 12-month long term. As far as the commitment that you would be making, it's about one check-in meeting per month, some draft review of materials before they go out to the full committee from staff, and also some presentations given at other meetings or with other committees. The current chairs are eligible to rerun if they would like to, but anyone else can run as well. And just please let me know soon if you are interested in that. And then I don't know if Jorge, maybe you want to talk a bit about what your experience has been like as the chair and what type of commitments you think are required.
Correct. The team here is a pleasure to work with, and we meet and do shares meeting to review an interim between meetings, the past meeting, and plan the next meeting and strategically the year. And then we had communications and between meetings to organize and structure the agenda and portfolio for the year. It's an excellent experience.
Any questions about the committee chair and vice chair elections? Oh, and I've just been reminded, the chair or the vice chair of the Metrics and Scoring Committee will also be asked to serve on the Behavioral Health Committee as well. So that does add a bit more of a commitment there.
So our terms are a calendar year, correct? January to December.
No, so it'll actually start in October.
Okay. So October to September.
Yes.
Thank you. Thank you very much. Allison, do we want to remind ourselves, looking ahead into, speaking of October, the fall is coming, and fourth quarter of the year, that we have a planned in-person meeting, hybrid?
Yes, we are going to have another hybrid meeting in October. very similar to the one that we had in May, same location. I think we'll be sending out more information about that later, but everyone is welcome and encouraged to come in person. If not, we do have the hybrid option. And I'll send out the same materials that I sent before as far as parking and logistics and everything like that. So you'll be hearing more about that soon.
Thank you. So please do mark your calendars, and it is a great experience and opportunity to be in person and conduct this business in person, if at all possible, of course. It does require obviously more time to move our physical atoms instead of have the digital world bring us together virtually here, but very worth the experience. Thank you, Allison. Thank you, team, for all this work. So we now turn to the Oregon Health Policy Board update. I'm McPherson scoring Layson and OHPB Vice Chair Kirsten Eisenson. Kirsten, are you with us? Don't see Kirsten on the.
We may have to circle back on that. I don't see Kirsten here right now. So I think we could possibly move on to
The next. Okay. I do encourage you to see the Oregon Health Policy Board launch of the OHA strategic plan, which was one of the main events on the on this month's meeting. It is there are public releases of the strategic plan, which is has a couple of important implications for our committee meeting, but we look forward to Kirsten updating us. Thank you. Okay, so we're a bit ahead of time because our next item on the agenda is public testimony, which is scheduled to start at 9:20.
I think it was actually scheduled for 9:10.
Oh, great.
Might
So
be
we are 2 minutes behind. Okay. So excellent. So our Makers and Scoring Committee welcomes and deeply appreciates our public testimony. And we thank the committee members who listen very intentionally and discuss and process and take this testimony into consideration, and obviously our community partners, stakeholders who provide the testimony. Thank you for your time. Okay, so let's take it away. Public testimony.
All right, our first public comment participant is Stick Crosby.
Good morning, Chair Ramirez, the rest of the committee. Thank you, Allison, for getting me in here. It's funny, you all hear from me 2 months in a row now. I have submitted some written comments regarding the meaningful language access measure. I'm requesting that you all focus on the measure and hopefully treat it as a must-pass measure. To summarize my comments, I think it's pretty disappointing that only 21.3% of the visits of the highest performing CCO met the target of what they were of having an interpreter present for the visit. I'm a little flustered, so that's why my comments are a little off here. I'm just kind of fascinated that this continues to flail within the state with the 10-year goal of eliminating health inequities, and we can't get language access right. I think it's just very disappointing, the amount of money that we spend across the board, the way that we enforce this, the way that now at the federal level, the safe harbors have even been removed, and we cannot seem to provide language services to the Medicaid members in the state, along with a benefit that has a large amount of limited English speakers with the Cover All People plan. Like this just fascinates me that we can't seem to address this in our state. And it's very disappointing. And I always treat language access as a barometer whenever it comes to health inequities. If we can't get the most basic issue addressed in terms of communication, which is one that you can see, that you can hear, that you can feel in the treatment room, how are we going to address those that are more hidden and more subtle when it comes to discrimination related to race or gender identity or those types of issues? So I implore you to look at this measure. I implore you to look at it as a must-pass measure and to continue to support it, so that way the CCOs have something to address down in their network for development of value-based payments or quality metrics downstream. Thank you.
Thank you.
Thank you.
Next, we have Andy Walsh.
Good morning. Can you hear me? Okay, great. Good morning, everyone. My name is Andy Walsh, and I am the Senior Health Policy Advisor for the Children's Institute, and I reside in Ontario in Eastern Oregon. I also serve as a member of OHA's Health Equity Committee. I am speaking to you today to thank you, the committee members, for your dedication to not only improving health equity for all Oregonians, but for your commitment to improving the lives and outcomes of our youngest and most vulnerable children and their families. I've had the opportunity to observe this committee's process over the past several months as you listened to the input of dozens of community members. You heard stories from pediatricians urgently seeking care for their patients in the midst of a youth mental health crisis. You heard from childcare and early childhood providers asking for help as they navigate behavioral health challenges. And you heard from parents from urban and rural parts of the state desperate to help their children have a better life. You heard and you listened not only to approve this first of its kind in the nation metric for social emotional health for 0 to 5-year-olds, but to keep this metric as a priority by including it in the challenge pool. Thanks to your decisions and leadership, we are taking the opportunity to improve the lives of so many children, improving not only their social emotional health, but their mental and physical health long-term. And not only for those in Oregon, but across the country as other states look to Oregon's example. I also deeply appreciate the committee's thoughtfulness in your discussion around health equity and noting how this metric fits into that framework. So again, I thank you for your commitment and dedication to this complex work within this committee, and thank you for hearing and listening to the community. Thank you.
Thank you.
Okay, next we have Annie Valtierra Sanchez.
Hi, everyone. I'm gonna keep my camera off. I'm reading my comments. My name is Annie Valtierra Sanchez, and I am providing comments on behalf of a community member named Belen. She could not attend, but wanted to share her comments, and she decided not to attend due to language barrier, and also just having a busy schedule with her son. So this is Belen. Medical interpreters are very important. Language is a barrier that stops us from receiving services. I have a son who has very complicated conditions, and simply making an appointment has been a barrier. I used to live in the Portland area, and it was easier. I even had a bilingual doctor, so there was no need for an interpreter at times. I now have an interpreter through Allcare, and it's such a need for us as my son has various conditions. So we're often at doctor's appointments, in the hospital, doing therapy. We're always doing some medical procedure. At some point, I needed a home visit, and I requested a Spanish-speaking staff. They sent a monolingual English staff, and we couldn't communicate, so she couldn't perform what was needed for my son. I'm trying to provide this comments in support of the language access measure to be a priority, to continue to be a priority, and hopefully provide at some point the support to more medical interpreter bilingual providers. Thank you.
Thank you. Next we have, and apologies if I pronounce your name incorrectly, Apao Fuataga.
Yes. Good morning, members of the committee. My name is Appa Allen. I'm from Jackson County, and I want to share a little bit of my personal experience with my husband. He was put on workers' comp due to an injury. An appointment was scheduled, and as we arrived, my husband was handed a form to fill out. Due to language barriers, he handed me this paper to fill out for him and was not comfortable communicating with the person at the front desk. Ironically, I had just completed my interpretation training, which I was not able to be certified because a proficiency test is non-existent in the state of Oregon. And I also had learned that I would be the first Samoan to complete the medical interpretation class. Taking what I've learned, I kindly asked the receptionist that my husband needs an interpreter. I was taken aback when we were told that we would have to schedule 3 weeks out so that they can secure an interpreter, which ended up being on a video chat. Without clearance or a doctor's note, my husband had to go back to work, but was soon to be put on light duty until he was able to be seen by a doctor. For the sake of time, I reflected on this and realized how many like my husband that are within our community and across the state that don't have an apa'au. These problems seem to remain unaddressed, and our communities remain underserved because our people are not adequately represented or consulted about interpretation-related policy and funding discussions, resulting in furthering the exclusion and language access gap for our Indigenous communities. As a Samoan, we are deeply rooted in our traditions and culture, and language is not just a means of communication, it is an expression of our very essence as human beings, and I apologize. So I strongly urge all of you to support the language access and continue to have these discussions. Thank you for your time.
Thank you. I do not have anyone else signed up for public comment. Do we have anybody else here who would like to give comment? All right, I'm not seeing anyone, so Jorge, oh, sorry, was that?
I'm
someone?
jumping in. I know there's a couple of people maybe didn't get to sign up here on the call.
Yes, if there's anyone here on the call, you can speak up now and let us know if you'd like to give comment.
Good morning. I would like to participate.
All right, thank you, Daniela. Go ahead.
Good morning. My name is Daniela Regla. I live in Grants Pass, and I would like to share about how important it is to have interpretation at the medical field. For my culture, it's important to have someone who speaks Spanish at the doctor's office. I would like to see more people helping with the language. It is important to make people to feel secure when we come to see the doctor. Even it feels good to have interpretation at school too. I helped some people a few times at the doctor's office and sometimes at school. I hope I did a good job, but it is important for them to communicate with teachers or at the doctor's office. Even like in my case, my kids helped me a few times too. And I don't speak it perfect language, perfect English, but I ask for interpretation sometimes, especially if there is something that you need to understand. Especially if it's like at the doctor's office, you need to know something that is very important, which I think if you're going to the doctor, you need to understand what they're telling you. Thank you so much for letting me be part of this meeting. I hope to see a change after this because we really need a change. We really need interpretation here in Grants Pass. I'm pretty sure it's everywhere in Oregon, but I'm speaking for my people here in Grants Pass. Thank you so much.
Thank you. Do we have anyone else on the call who would like to give public comment?
Hi, my name is Paola. I would like to participate too.
Go ahead.
Yeah, thank you. Well, I will talk about also related to the language barriers and also the interpretations. I was at the hospital with my daughter, and it just was for infection. And in that moment, he arrives a man feeling really bad. It was another person was helping him, and they was trying to speak to someone in the hospital in the ER, and no one could help because it was no interpreter, and they was trying to put the telecommunication, but the internet, it didn't work, and that man was having a heart attack. And in that moment, I saw that no one was helping him. So I stand up and I say, well, I understand the language, but I'm not professional. So I was trying to turn, but he was really scared, that guy, because no one was helping him at the hospital. So that's why it's so important to have person the language. And I want to talk about all the people that doesn't speak the language, and also at the schools too. It's very important because sometimes kids, they interpret it to the parents something totally different what the mom said, or because probably they failed a class or something. So that's why we need more persons, more professional confidentiality, that it will be more helpful for all the parents and people to say the right words. And thank you very much to listen to me and the participation in here. Thank you.
Thank you. Do we have anyone else on the call who would like to give public comment?
Thank you, everyone, for your participation in this public testimony. We respect and value your participation as a stakeholder, professional vantage point, personal lived experience. It is very valued, and no need to apologize. Thank you very much. If we do allocate 10 minutes or so for this portion. If anyone else wants to provide comment, please do so also in writing if you didn't have the participation time at this slot today. Let's move forward in our agenda. Our next item in our agenda is to finalize the challenge poll. So in our last meeting in July, we had the opportunity to examine challenge poll options and drafted a challenge poll. We selected the child level socio-emotional metric because of its importance, population health value, and enormous support through public comment and different community engagement venues. We reviewed the results of our survey that included a challenge poll and a couple of the measures, two measures that received the very top scores. Postpartum care and child and adolescent well-care visits received the very top scores on the survey, are included in the draft challenge poll. We also included preventive dental or oral health care services. So we have in front of us this set of 4 measures. We consider briefly the possibility of having a health equity subset focus based on 4 measures that are disparity sensitive because of their known high relevance and importance to racial and ethnic minorities. We also briefly considered drawing from the community health improvement plans and summaries about what the community has brought for us priorities. But we landed on these 4 measures, and they're important measures. I believe they all are the same as last year's. And that's what we have as a draft. I have a couple of recommendations, but I'll open up the floor for any other observations about our process or additional viewpoints since our last meeting in July. Yes, Lourdes?
Thank you, Jorge. I actually have a question regarding the child level social emotional health metric. I don't recall that we saw it when we were during the survey for the benchmarks. Is that correct? It sounds like we're still trying to gather information while also trying to put this challenge or this metric in a challenge pool. So if I can get more information on that, that would be great.
Yes, that is correct. It was not included in the survey. The reason for that is that the measure steward OPIP is still currently gathering information and feedback, and they are going to present a benchmark recommendation to the committee at your September meeting. This is going to be the first year of the child level social emotional health, but the data has been collected, and so there is going to be baseline data in order to come up with a benchmark recommendation. So yes, you would be voting on this measure to include in the challenge pool without knowing what the benchmark recommendation is, but you will be hearing that recommendation at your next meeting.
Allison.
Thank you.
Oh, go ahead.
Yeah, I was just going to say thank you. We look forward to the September presentation of those data. Go ahead.
I was just going to clarify, Allison. So for 2025, it won't be report only. We will have an improvement target and a benchmark, correct? Okay.
Yes, that is correct. It will not be reporting only. And I see that Colleen Rulin from OPIP is here if you would like to speak on that a bit more, Colleen.
Sure, yeah. I mean, as you all know, since 2013, the vote on challenge pool has always been done before benchmark. They've never been at the same time. And aligned with our goals to make sure everything is community informed by parents, providers, and CCOs, we wanted to make sure for this metric, because as you know from your benchmarking guidance in your chapter and your rules, it's normally based on the kind of the national benchmark and comparing to national benchmark, but there is no national benchmark for this. So what we wanted to do is honor like community level feedback about what would be fair, what would be reasonable. And so we're doing those public comment sessions end of August and September in order to come to you with a recommendation that's anchored to parameters that are patient-centered, but also anchored to feedback from CCOs and healthcare providers about what would be feasible. We couldn't do those benchmark input sessions until you finalize the set. And so the reason we had to wait, so I literally sent out the email about the benchmark input sessions after the July meeting because it would be inappropriate to be facilitating meetings around a benchmark set if you guys hadn't included them in the set. And so that's why we are coming in September with those recommendations that will leverage that benchmark tool that you're seeing, but also get community input about what's fair and reasonable, given that this is a unique system level metric and we need to be really thoughtful and careful about what we expect in terms of a benchmark.
Thank you, Colleen, for the OPIP and all the community partners for this glide path measure. That's been years on the making. It's a pivotal year in which we're switching to benchmark improvement targets after all that amazing amount of work. Thank you. Leona?
Yeah, Colleen, I really appreciate that you're doing all of that legwork to communicate and listen to the community for setting the benchmark. I'm hoping you can help me understand one thing. It sounds like originally when this was going to move to child level specifications, there were about 100 codes that would be included. And then in the final specs, there's about 40 codes, and it cuts out a lot of the codes that primary care uses. And so it misses a lot of what's happening in the primary care setting. Could you speak to that and correct any of that if I'm wrong on that?
Sure. And I don't know if my medical director is on. Yeah, so in the original glide path, and in the original metric, we were looking at the system. And the system has a lot of different roles, right, Leona? Like you play a role in doing awesome population-based screening and surveillance. And actually your current well-child visit metric is capturing and incentivizing a lot of what should happen in primary care. So that population-based screening, that awesome brief intervention and coaching, we've actually already been incentivizing the last years. It's actually the first metric that went into play in terms of well-child visits. And so from the very beginning in the system level metric, we said that we're going to give you data in component one. I think that's maybe what you're referring to in terms of the large number of codes that's looking at all the different roles in terms of the social emotional services. And we were very explicit that the child level metric would be focused on a subset of that. And it's been very explicit in the system level metric that is focused on when children have issues, the types of interventions, and how do we think through the kinds of workforce that are going to be needed, that are people with expertise in issue-focused interventions, and how do we transform that behavioral health system? Because again, this is the third of a three-part metric set. And so you know, as CCOs, they're accountable for physical, behavioral, and oral. And so the physical measure is incentivizing exactly what you're talking about, like a lot of that great work for primary care. This metric was really trying to think through, again, given the data and given the need, how do we make sure that we have services for families when there are issues identified? But recognizing for young children, that's going to be across a number of systems. That could be in specialty behavioral health. That could be in integrated behavioral health, which is in primary care. So there's a number of codes, and we listen to a number of primary care and behavioral health providers about that. And it also could be in community-based organizations. So the reason that the child level metric is less than that first broad part, although they did get the data for segmented for the second part, is because we always were talking about that we wanted to focus on issue-focused interventions. And part of that is, as you heard from numerous parents, providers, and others, that when children are identified, there's not a service for them. And so we're trying to transform the system. And so the metric is anchored to that. So that's where I'd be happy to resend a lot of those input sessions. And in terms of the glide path of the metric, that's why they were given the big part. Because as you know, when you're trying to get to issue-focused interventions, there's root cause analysis. Is it that people aren't getting in? Is it that they're not getting identified? So the system level metric was meant to help them think through the system. But the action plans, and the reason why it always has been incentivized to that subset of the metric was around the issue-focused interventions. Lydia is a pediatrician and primary care provider who also facilitated a lot of those input sessions. Is there any other context that you would provide to Leona that could be helpful?
Yeah, Leona, I really appreciate you bringing up this question. I think that a lot of the feedback, when we had the input sessions, we did talk through sort of what the current codes that were included were and sort of where we're going towards with this glide path to the child level metric. And in the end, we got overwhelming feedback that we actually don't want to be incentivizing or focusing on the screening and the early parts, which is that early part that you're talking about and some of those codes that are no longer included, because we really want to focus on once we've identified the children, what do they have available to them? And so that is the sort of outcome of the input sessions that we had. We did get some feedback about some of the codes that are sort of the initial assessment that happens in primary care, but because it's happening in primary care, often it's an initial assessment and the first part of intervention. So like the health behavior assessment codes, there's a psychiatric diagnostic evaluation codes, those we kept in. And so there are a few of those codes that were in that broader set that we included based on that feedback that we don't want to eliminate what the great work that's happening in primary care. But it's work that's happening in primary care by behavioral health specialists that can kind of do that first part of getting children with identified issues into supports and services. I hope that's helpful.
But the denominator is all children, it looks like.
Yeah.
So we're not expecting 100%.
Not at all.
No, that's
not
why we
100%
really,
of kids need intervention.
Not at all.
No,
Yeah, okay.
yeah, that's why we really want to give you, that's one of the parameters in the input sessions. I hope you all come, because this was a really explicit decision because we don't have a system that provides diagnoses. If we narrowed down to diagnoses, we'd be disincentivizing the very system that we need. So for you all as a metrics and scoring, your benchmarks for this metric are going to be different than any other metric you've ever had, which is why we want to be able to give you concrete advice. One is, this is not specific to one sector. This metric includes specialty behavioral health, includes primary care, includes community-based. And so you need to be really thoughtful about that. Second, this is a population-based metric around interventions. So to your point, Leona, the goal will never be 100%. Thankfully, we have population data, we have trending data. The third is we are trying to transform a system. And so to expect massive levels of improvement in 1 year wouldn't be honoring what this metric is trying to do in terms of improving a system. And so that's we have 4 parameters that we're going to be discussing in the next month that lead us to our recommendation. And that's an example of one of like, let's look at the data the last 2 years of what CCOs have been able to achieve in terms of improvement on this child level metric. Let's think about the goal and intent of system transformation, and let's think about what would be actually fair and reasonable in a year.
Thank you for the rich discussion on the socio-emotional level of child metric and its goals, ambitious, transformative goals across sectorial, across healthcare sector goals to address the healthcare needs of children at this age. That is an ambitious goal. Sometimes we call that aspirational, and we're trying to make that concrete and achievable and feasible through the examination of data and community input. Very important work. And just a kind reminder that this measure is one of the ones with the highest return of investment, because if those needs are measured and addressed early on, they are going to be predictive of positive health trajectories in those young lives. Very important innovative work being conducted by our state. So we do have a set of 4 measures, unless there's any other burning questions about the specific one. Any other observations on this set of 4 measures for the challenge poll? We do have a theme of continuity, such that these measures have been with us for a long time, either in the making, in the glide path versions, or just basically from CCO 2.0. Some of them go back to CCO 1.0. There's a continuity measure, and there's early childhood measure. Early childhood emphasis and emphasis on young lives. Yes, Leona?
Yeah, I appreciate the discussion that we've had. And this is something that's really important, without a doubt. And it's something that I've been working on in our regions, not because it's a measure, but because there's so much lacking for our children, especially those who need additional support. And I continue to feel nervous having this in the challenge pool the first year that we're doing the measurements, and wonder if there's anyone else feeling that way, if we could have the first year with it in the quality pool and not the challenge pool, while we get baseline and learn whether the initial benchmarks and measurements are working the way that we would want them to be able to measure what we want to measure. And I can only speak for my region, but this is not an issue of we have providers out there who just aren't in network for our OAP members. This is an issue of the providers are not there. And so we are working on recruiting and retention really specifically, including for children's care. But that's not, I have some angst about doing this the first year in the challenge pool. So Those are things that take a long time to change, which is not to say that this is not something we should be focusing on, but just that I feel angst having it in the challenge pool the first year that we're doing this child level measurement.
Thank you, Leona. Stephanie?
Yeah, thanks, Leona. I hear that this was in the challenge pool last year, but that was when it was still more qualitative, right? In terms of like the building up of things. So I think that runs through my mind in terms of, right, it's the same language, but actually the metric now changes with it being here. At the same time, and Allison, correct if I'm wrong, right? So, and also it'd be helpful, Leona, and I think Courtney, and who actually are at CCOs. And so, right, you all get this list of these metrics and have a conversation with your respective teams about, we're going to try to tackle all of these, but there might be certain ones that like we really want to, you know, push for this year to try to meet that benchmark and have some improvement. And so that's right, the overall incentive program. And then there's, if there's money left, right, that's where the challenge pool, and that's like that extra incentive. And so it's not just because it's in the challenge pool doesn't mean that people have to shoot for this one. So I think that's the other thing to keep in mind too, is that this is about the extra pot of money that potentially, and right, we never know, right, Allison, until later on what that pot actually even looks like for then CCOs to then go after. So I hear your point, but I also I think what I feel like is that just because it's in a challenge pool doesn't necessarily put it on the CCOs that that's something that they have to, ideally they're tackling, but they don't have to like totally meet the benchmark right now because you're still in the learning phase. But by having it in the challenge pool and thinking about to the numerous public testimonies and written testimonies we had about this, I think having it in a challenge pool makes a statement about how important this is and that we CCOs need to, over the time, keep working at this and keep pushing at this if it stays in a challenge pool.
Thank you, Lourdes and Courtney. Lourdes?
Thank you, Leona and Stephanie. I originally brought up the question because I was feeling pretty similar to Leona's. You know, I just feel like we're still working on developing this. And I wasn't here last year when it was set in the challenge pool, so I can't speak to that or what those conversations were. But I just feel like we're still trying to work on a lot and get feedback. And I'm grateful that we're trying to get feedback and we're trying to get different components and you know, gather all that information. I am grateful for that. I also do appreciate all the comments and public comment that we received. However, during that public comment, some of the things that I heard, and you can correct me if I'm wrong, but it should be in the challenge pool so that CCOs can prioritize it. It should be in the challenge pool so that it can be, so that CCOs can be held accountable for it. And I just don't know that those reasons are truly the reasons to put it in a challenge pool. And so while I acknowledge it, and I do agree that this metric area is very important, I do agree that this work needs to be done, and I do agree that we need to improve on it. However, like I said, some of that public comment and the reasons for it and why it should be a challenge pool while we're trying to develop it, I just have some concerns about that, but I'll stop there.
Thank you, Lourdes. Courtney?
Thanks. Yeah, thanks, Lourdes, for those comments. And Stephanie and Leona, I think just to respond to Stephanie, your explanation of, you know, maybe how CCOs approach the measures. You know, of course, I'm speaking on behalf of my CCO and I've worked for another CCO. From my experience, we don't, as CCOs, pick certain measures to focus on. We focus on all of them. All of these measures are very important, as we all know. And so CCOs, you know, are working really hard to address all of the measures. There are certain measures that are more challenging for CCOs depending on their service area and their population. And so, you know, the fact that the CCOs only need to meet 75% of the improvement targets out of the total measure set, it's not that we're picking certain measures to focus on so that we can achieve improvement targets. It's it, I think. Manu, not to put you on the spot, but I think last year you had some concerns, and maybe you, Jorge, too, about having a measure, a challenge pool measure that was just an attestation-based metric, right? And really wanting them to focus on the more outcome-based metrics like this child level metric. So I think we as a committee were excited about having the child level metric available to include in the measure set. But it is, I think, the first time we've ever included a challenge pool measure that it's the first year of measurement for that measure. So that would be kind of a change, but I also want to be responsive to all of the public comment that we received and all of the work that's gone into developing this measure with a tremendous amount of community and provider feedback, which is very, very important and unlike a lot of other measures that we have in the set. So those are my comments.
Thank you, Courtney. I can speak for myself in terms of the perspective of having challenge pool measure in its formative glide path important stage, yet not having quantitative data for benchmarking. And that perspective is basically that challenge pool is an opportunity to obtain funds by focusing on providing extra focus. And thank you for the reminder that our healthcare organizations work hard on every single measure, irrespective of what their challenge pool or not. But there is a perspective that, as the name challenge implies, that there is an extra challenge in meeting that expectation, and it has been practiced, to my knowledge, that higher, for example, benchmark and/or impairment target is set on a challenge pool measure for the challenge aspect of it, right? Different than the quality program expectation. So I just thought that it would be a good opportunity to focus on measures that hit those benchmarks already. So that was the perspective. That said, there is a history of including glide path formative measures in the challenge pool prior to benchmark data being available. I believe the health equity measure is another example that it was included in the challenge pool a couple of years ago before the benchmark data were available. Manu?
I largely agree with the tenor of what everyone has shared, particularly as it relates to the idea of setting a measure within the challenge pool which hasn't yet been benchmarked. And so with that, I would like to ask a little bit of a process related question. While I know that today was intended for finalizing the challenge pool, is it possible to postpone finalization of the challenge pool after we receive potential benchmarking data for the child level social emotional health measure specifically?
Thank you, Manu.
So I think the question was directed to OHA, if that would be possible.
There is data in the benchmark selection tool. So if you're looking for some baseline data, that is there. I mean, we have largely deferred to the OPIP's process for giving a benchmark recommendation. But the data is there if you want to explore it, if you're curious, where that might land or where your thinking might be there. And I think to Colleen's point earlier, this decision does precede benchmarking, so that's not out of step necessarily. I guess I'm not uncomfortable if this goes till next month, but I don't fully see the reason necessarily.
That's a possibility. Thank you. Courtney?
Sorry, I was going to look at the benchmarking tool again to look at the baseline data because I kind of wanted to ask, Manu and those who, maybe want to postpone. I just want to understand, the reasoning for it. Because I think from my perspective, it's not that we don't have a benchmark set yet or, looking at the baseline data, I think would be important. But I think it's more just that this is the first year of the child level metric. That would be the only piece that, maybe would cause concern, just because we've never had it as a measure. It's not that we don't have benchmarking information. It's just that this is the first year of the measure. And historically, the first year of that part of the measure, we don't put in the challenge pool. So I think that is the only, from my interpretation, I think that's maybe where the main concern is. But please correct me if I'm misinterpreting.
Could we get maybe a fact check from OHA regarding the statement that Jorge had just raised, that we have had a the meaningful language access for the health equity QIM has been a part of the challenge pool, even though we hadn't had a benchmark for it at the time? Is that, I don't recall that. I just would like to confirm that and verify that.
Yeah, I'm going to jump in there and OHA can correct me if they would like to, but when we had it in the challenge pool, it was when it was in the component 1 portion of the measure, where it was only the attestation component portion, not the component 2 outcomes-based percentage measurement.
The formatted stage, much like last year's inclusion of the challenge pool of the child level social emotional metric in the challenge pool prior to the benchmark data being available. So we have allocated about 10 a.m. to conclude and finalize our set, and there is clear recognition about the importance of this measure and enthusiasm by our committee and the stakeholders and responsiveness to the community engagement and public comment. There's no doubt about that. That has been restated. There is though some concern about the uncertainties of the first year in benchmarking and in including it in terms of the very first year. And I can see us either removing it from the challenge pool or keeping it as a dichotomous decision for today in the finalization of the challenge pool, and keeping it with the also intention that the first year's benchmarking is going to be, we usually start with the realization and basic acknowledgement that during the launch of a measure, the benchmark has to be calibrated to that reality, right? So that would be a way to keep it in the challenge pool and say, well, when we benchmark it, we're going to take that into account, and that it is the first year. Or as a committee, we can decide to remove it from the challenge pool. That's what I would propose, that we consider those two options to move forward today. Yes, Courtney.
Sorry to interrupt, and sorry, Courtney, as well. I just got a message from Hidayah saying that her hand raising function is not working on her end. So I think she has a comment as well, Hidayah, if you'd like to jump in.
Yeah, thank you so much. So I'm also concerned about placing it in the challenge pool, and I just want to know what happens next if it's not included in this draft. Will it remain in the challenge pool next year, or what is the process?
I mean, it's been voted to be included in the main primary set, so it's still incentivized. And the incentivized list and the challenge pool are reconsidered each year. So it could certainly be an option next year. Yeah.
So the work will continue, the benchmarking will continue, and it'll be part of the quality incentive measure, and there will be improvement targets set regardless whether it's in the challenge pool or not. Hidea, please do unmute yourself and jump in there. Don't let the technical difficulties stop your participation. Yes, Courtney and Manu.
I'll be brief. I know we need to move on with the agenda, but I just wanted to kind of clarify my stance. Like, just because we haven't historically put a measure in the measure set when it's in its first year, doesn't mean that I don't think that we should do that. You know, of course, taking into consideration kind of historical decision making of the committee is important, and I know that's informative to all of us. But I don't think that it means that we shouldn't include it. And I'm still in favor of including it in the challenge pool in response to all of the public testimony that we received on this measure. So I just wanted to clarify that.
Thank you, Courtney. Manu?
I think as a committee, we each need to consider what the challenge pool means to us. And you know, and what our personal expectations are being driven forward with the challenge pool. So one interpretation of a challenge pool can be the exceptional aspirations that we desire to drive healthcare transformation into. And the crazy thing is that the quality incentive measures that we've already selected are already quite aspirational and exceptional in its own right. You know, I'm personally conflicted. What I'm leaning in more is a precedence of putting something that has no benchmark. While I myself haven't reviewed the data specifically, you know, putting something without a benchmark and keeping it within the challenge pool. And at this time, I'm largely conflicted and wanted to share with the entire committee for each of us to reflect on what the challenge pool means to us individually, and see if that resonates for each of these things to move forward or not. Thank you.
So it seems to me that the concern about its inclusion is not necessarily what the data will be when we see it and consult it, but the principle, the precedent of having to work on a measure for the first time and meeting a benchmark, even though it's the first time, and be that part of the challenge pool. So I am in favor of finalizing a decision today rather than postpone that, because it's not the data per se, but the principle that it's giving us pause and setting important considerations here. Let me propose, since we're have gone over the allocated time for our finalization of the challenge poll, do you want to take a straw poll on whether you would like to include it? I hear voices of concern to not include it, and then about half of us or maybe more of us I'm in favor of including it, with the caveat that we would take that into consideration in the benchmarking next month. But of course, it's important to have our collective voices here represented in this decision.
I have a couple things. I just want to reiterate that in the history of the program and the process of selecting measures, then selecting the challenge pool and the benchmarks, we haven't ever had the benchmarks selected for the measures prior to the final vote in the challenge pool. So this wouldn't be different from how that had been done in the past. The other thing is, you can certainly make a motion and take a vote, and if it doesn't pass, it doesn't pass. So if you want to just go ahead and do that, you are welcome to, or you can continue to have your conversation.
Okay, so thank you. So it's an important reminder that we can take a vote. We have a theme of continuity in this set. These measures are continuity, yeah, a very important considerations for the specific measure that is moving from its formative stages to its formal operational benchmarking quantitative phase. But we do have the theme of continuity. I had a nay vote last month, given my proposed impetus on having a focus on health equity measures based on disparity sensitive aspects. But I do value the continuity that the set provides for the challenge pool and its emphasis on children prevention if we look at developmental phases as a prevention component. I see Stephanie's hand. I would ask you to consider the inclusion in this set of an additional measure like the health equity measure that doesn't take away for the impetus and the value of the set as a whole. So please consider the health equity measure to be part of the challenge pool. I would also ask you to consider the behavioral health measure, given that it's part of the strategic priorities that were unveiled this month of the Oregon Health Authority. And it's part of our states, one of our 3 states priorities, major priorities. So I'm supportive of this set and ask you to consider a health equity and or a behavioral health measure to add, not to subtract from this subset. Go ahead, Stephanie.
So I'm probably going to throw a wrinkle, but I was going to say to subtract, is there another metric that we would want to put in instead that people would feel more comfortable about if there is some kind of wavering on keeping the child level social emotional health, given that it's the first time with an actual quantitative metric? Is there another measure we can put in instead for this year? I would throw in diabetes, just hearing what Jorge say, I would throw in depression screening. But
yes, Leona.
Yeah, I would second the A1C, the diabetes measure, because it pulls in adults outside of pregnancy. And there's all sorts of room for work on equity in that measure as well. And we still need to do quite a bit of improvement on it.
Thank you. Additional thoughts on adding measure to this 4 or perhaps the 3 of the 4? Go ahead.
Sorry, I'm sorry to interrupt. Just one more thing to say about the social emotional health measure and the benchmark. You are going to get recommendations from OPIP for the benchmark in September. However, it is ultimately up to you all to choose the benchmark. You don't have to go with whatever is recommended to you. So whether or not it's in the challenge pool, the benchmark choice will ultimately be up to you. And that's all I have.
Additional thoughts? Discussion points about adding a measure other than the 4 that we had been to emphasize behavioral health or health equity.
I like the idea of the focus for 25 to be on kindergarten readiness. And alignment with that, 3 of the 4 that we have on there is for young children, and postpartum care is leading into that as well. And so I think I'm sitting with the 4 that we have on the deck for that reason right now, in terms of what I view the challenge pool should be for 25.
I agree with that, Manu. I am comfortable with the draft set that was already established for that reason, for the continuity reason, for the reason that it factors in kind of all the things that we've discussed historically as reasoning for the challenge pool. We want representation across physical health, behavioral health, and dental. we also want the a disparity sensitive measure at minimum involved in the challenge pool measure set, which is part of the reason for including postpartum care. So I feel like we have a really good, well-rounded set. I'm hesitant to include a fifth. If the conversation is around replacing one, then you know, I'm open to that, but I don't think that we should select more than 4 because it kind of takes away from the purpose of the challenge pool, in my opinion.
So would you like to proceed by ruling out an additional measure that is not this 4? Is that a fair way to proceed? Team, would you rather vote on this 4 that we have in front of us?
I think we should start with voting on the 4 that we have in front of us, and that will get a good idea of what everyone's thinking right now.
Yeah, I agree. I'll make a motion to move forward with the 4 measures on the slide: child and adolescent well care visits, postpartum care, the child level social emotional health measure, and the preventive dental measure for ages 1 to 5 and 6 to 14 as the 2025 challenge pool measure set.
Now, if we vote on that and finalize it, then there's no room for an additional measure, correct? Because once we voted, we finalize it. It's not a draft. Just want to make sure that would be the implication. So basically, voting on this 4 would eliminate the option of a 5th. Just want to clarify what the vote would mean.
That's great.
Okay. So is the committee okay with that, or anybody else want to consider a health equity measure or a behavioral measure or a diabetes A1C poor control?
I would take a step forward and second what we have. However, I realize that we're kind of keeping it up to everyone right now to determine which way we should go. So we can take it from there.
Oh, it seems that we have, I don't hear any additional objections to this vote. And or support for a health equity measure or behavioral health measure. Yes, Stephanie.
Well, I was going to say, I mean, Jorge, you can also make a motion if you want to throw in diabetes and either take one of these away or add a 5th, and then we can see if we can get a second on that.
Correct, but I don't see support from the committee, so thank you. Thank you for the reminder. I'm not sensing a lot of impetus, so there's working with the committee and there's imposing on the committee. So thank you for the reminder, Stephanie. Very appreciated.
So we have had a motion from Courtney and a second from Manu. So
Correct.
I'm going to go ahead and go through the vote. And I will start with Courtney.
Approve.
Stephanie.
I don't approve.
Manu.
I approve.
Curtis.
I don't approve.
Hidea.
I don't approve.
Jorge.
I approve.
And Leona.
I do not approve.
Okay, so that is 4 no votes, 3 yes votes, which means that the motion does not pass.
Okay, thank you very much. So for the do not approves, what modifications would you like to propose?
I propose that, I think what I said before, that we remove the child level social emotional health and replace it with the diabetes metric.
Okay, additional modifications from the committee members who did not approve.
That's also what I would move forward with. I'm not sure if that was an official motion. If it was, I second.
You have to be careful with me, Leona. Sometimes I try to throw in those motions.
I'm in favor of motions to move us forward, but I'm also trying to attend to the whole committee's opinions and not. since there were 4 no votes. Trying to be inclusive here.
And just for my clarity, Lourdes and Hidea, would you mind sharing what your perspectives and rationale were regarding the no vote? Were you considering the same as what Stephanie and Leona have supported?
Yes, Manu, for me, it was what Leona and Stephanie indicated.
Same. Sorry. Yeah, mine is also same, and some words were basically so if we replace something a different agenda with that would go very well, like diabetes or something else, that would go very well. Replacing the child level social emotional health.
Okay, so I would welcome a motion with that modification.
Okay, I'm gonna try. I'm gonna make a motion that for the 2025 challenge pool, it consists of the child and adolescent well care visits, ages 3 through 6, postpartum care, preventive dental oral health services, ages 1 through 5 and 6 through 14, and the diabetes A1C metric. I'm sorry, I don't have the exact language right in front of me.
I'll second.
Roll call, please.
All right, let's start with Jorge.
Approve.
Courtney,
I do not approve.
Stephanie,
Approve.
Leona,
Approve.
Manu,
I don't approve.
Hidea,
I approve.
and Lourdes.
I approve.
All right, that is 5 yes votes and 2 no votes, which means the motion passes.
Excellent. Thank you very much, everyone, for the very important considerations brought forward on the challenge poll set, reminding us about the importance of the subset that plays its role, even though our healthcare organizations strive to achieve all of the health components in the entire set. We have had an important discussion about the one measure changing in this pivotal year, and have included an emphasis, still a predominant emphasis, on preventive and child health, plus a very important topic for health equity, the diabetes H1AB for control. So our final set includes the 13 measures we approved last month, and our challenge poll as just voted on and stated. Thank you very much. Our set is now finalized, including the challenge poll subset. In September, we're planning a brief summary of our set that will take into account its major characteristics, including its challenge poll. For example, we have 2 to 4 measures that have been in our entire history since 2014. We have glide path measures well represented in our set. And I believe all of our measures, except a couple on the glide path, have been for the length of our CCO 2.0 that are 4 years or older. So we have a really strong set that emphasizes continuity, and including the challenge poll, of course, inclusive of the challenge poll. Let us turn our attention to our second major task, which is a benchmarking. We, our colleagues to prepare us here at OHA Analytics, prepare a benchmark selection survey that provided us the opportunity to work through all the measures and the possible and the recommended benchmarks and improvement target floors that we can use as a basis to start our process to set those improvement targets. So Allison is going to present. We're a little behind on our agenda, but for good reason. I recommend that we review these results and then take our break and then initiate the process of benchmarking. Would that work? Okay.
Can we take the break now just to separate? We just had this big discussion and vote. So can we take the break now and then go into benchmarking results and decisions?
So that's another good option. Switch gears through a break. Is everyone okay with that? Excellent. So let's take a break. It's 10:21. We'll see you at about 10:30. We will be back at 10:30. Excellent. Welcome, everyone. It is 10:30. Welcome back. My video has ceased to work. Okay, there it is. Welcome back. It's 10:31. We are launching now the benchmarking phase for our 2025 set. Thank you so much again for the survey preparation and preparation of the summary of the results. Allison, please take it away.
Thanks, Jorge. So I'm going to give a brief overview of the results from the benchmark selection survey. The full results were included in your meeting materials, which I'm sure you've all seen. Next slide, please. All right, so just for context, 12 of the 13 2025 incentive measures were included in this survey. As we've talked about previously in this meeting, the child level social emotional health measure was not included in the survey, and that is because OPIP, the measure steward, will be presenting their benchmark recommendations at next month's meeting. Also of note, we only had a staff recommendation for the 1 to 5 age group for the preventive dental measure included in the survey. This is because the 6 to 14 age group was only added to the set at the July meeting. And so we had yet to come up with a staff recommendation for that benchmark by the time the survey had gone out. We do now have a recommendation for the 6 to 14 age group. It is included in the benchmark selection tool, and we can also go over that later during our actual selection of the draft benchmarks. Next slide, please. So in the survey, committee members were asked whether or not they agree with the staff recommendation for each measure's benchmark, their reasoning behind that decision, and then any other benchmarks that they would like to consider for that measure. The committee members were provided with multiple resources to assist in making these decisions, including the new benchmark selection tool, a benchmark selection handout that covered the qualitative components of measures that were not in the benchmark selection tool, and then also kind of a benchmark orientation primer video that had been used previously as well. Next slide. So these are the high-level results from the survey. The table is organized from most to least agreement with the staff recommendation. You'll see that there was no unanimous consensus either in agreement or disagreement with the staff recommendation. I've also included a column here to show which component of each recommendation had disagreement. So for example, if you look at the first measure, the assessments for children in ODHS custody, the disagreement voiced in the survey was in reference to the benchmark only. There weren't any comments made actually about the improvement target floor. Some measures had disagreements with the improvement target floor and not the benchmark, and then some had disagreement commentary about both the benchmark and the improvement target floor. And then later on, when you're actually making the benchmark selections, we have a slide for each measure that'll go into a bit more detail. It has your comments summarized and also the votes on them as well. So you are able to go measure by measure and see more detail for each one. That is the summary of the survey results. Any questions?
Questions, comments about the summary of the survey results?
If there aren't any questions, I'm going to turn it over to Jorge to let you guys jump into the benchmark selection.
Thank you, Allison and colleagues, for preparing this survey. In summary, I recommend that we move forward with our benchmark process if we follow the rank order of agreement on these measures. So we go back to that one slide with if you don't mind going back. Well, we have prepared actually the consideration of each measure based on the rank order agreement on the survey results. If we can just briefly show that one more time. A survey results slide. You hit that survey results slide. Thank you. So you will see that 6 of the measures had majority approval, meaning more than 2/3 of the committee, 6 or at least 6 individuals. And then we get closer to a split decision, and then disapproval, clear disapproval. So what we will do is cover each of the measures based on that rank order. Thank you very much. So let's move the slides forward. And our first measure to be considered is health assessments for children in ODHS custody. Thank you. The benchmark is set for the measurement year 2022 at the CCO 75th percentile as a recommendation of 93.2%. And a Minnesota method target floor for 3 points. A really brief reminder here that the Minnesota method asks us to make annual improvements. So we can, each organization can meet the benchmark or an annual improvement target of a 10% improvement between the organization's baseline and the benchmark. And there are circumstances in which that percent improvement can be quite small, less than 1%. So the Minnesota method provides percentage floors, meaning if the annual 10% improvement is lower than 1%, we can decide that it should be at least 3%. The survey results state that there's 8 individuals who agreed and 1 who did not. And the feedback is that it should be higher than in the previous years. So this benchmark is close or the same as last year's, and there's expressed concern over that. And alongside with that observation, there is a comment to consider slightly higher benchmark of 94.5%. Questions, comments now on this recommendation of the benchmark in improvement floor?
I don't know if you can see me, Jorge. I'm just going to make this comment now, but it's a comment that I have across the board. This survey was a little tricky for me to complete because I could be misremembering. I feel like usually we get a presentation by OHA in terms of their recommendations and why. And I feel like I was missing that. I love the tool. The tool is great, but I was missing but why did you all set it to this benchmark? Why are you all recommending this benchmark? So then I can have that information in my head while I'm then taking a look and looking at the trends. And the other thought that kept occurring to me is, will these CCOs ever reach that benchmark or improvement target? Are we, I think Courtney spoke to this earlier in terms of, because of structural barriers, low resources, they will never hit that benchmark or improvement target. And so that was something that kept going through my head too, is those CCOs that are lagging behind and perhaps are consistently lagging behind on particular metrics. How does wherever we set the benchmark or the improvement target or the floor, how does that, making it challenging and aspirational, but at some point there needs to be a larger conversation about, are we just kind of setting benchmarks, and that there's always these CCOs, because of the structural barriers, they will never be able to reach it. So those are the things that went through my head while completing this survey. So I just thought I'd say that now. So if you guys are looking at any of my comments that I made, that's partly why for some of these, it was confusing to me to either agree or not agree, because that's what's going through my mind.
Thank you,
Yeah.
Stephanie.
That's a good point, Stephanie. And it's hard too, because, you know, the CCOs the data is blinded, so we can't see which CCOs are performing. And I know OHA, I'm sure, does that for a reason, but, you know, looking at historically, are the same CCOs, you know, performing lower on certain measures? I feel like that actually might be helpful for us to look at some point. But I think to your other point, Stephanie, kind of along the same lines with this measure in particular, it feels like this is the highest benchmark percentage we've ever set for any measure. And I'm starting to wonder if there's like a maximum threshold that we can even set for a benchmark, because eventually we're going to hit 100%, and that's not a realistic expectation. And this measure, I mean, all the measures are complicated and have a lot of nuances, but some of the CCOs have really small denominators for this measure in particular. And so missing one kiddo could completely, you know, break their chance at meeting the target. Or perhaps they, you know, if we set a benchmark of 94.5%, they might actually have to achieve 100% because of their denominator size. So just those are some things that I'm kind of thinking about as we start to creep towards 100% as a benchmark.
Thank you. Leona?
Yeah, I agree with those comments. And this, for this metric in particular, I do think we're maxing out how far high we can push this. And when you look at the trends over the last several years, besides 2020, it's the same performance across, you know, on average. So I'm feeling like we've probably done what we can in the system for this particular measure, which is not to say we shouldn't continue to work hard for these children, but in terms of the measure itself, I don't think we can push this higher. And then in general, I disagreed with most of the recommendations, and I wanted to explain why, because it's a theme. And the theme for me is that if we set an aspirational benchmark, we really don't need those floors. So if our aspiration is 95% for whatever measure, then automatically every year, each CCO has to close that gap by 10% of the gap. So we're already pushing everyone to get closer to that aspirational benchmark. And as you get closer, there's less work that you can do to improve that particular situation, just like we're seeing with this measure in DHS. And so what I'm wondering is, can we just set aspirational benchmarks across the board and not have to worry so much about the floors? Because it's automatically, the way the Minnesota method works, it's automatically pushing everybody up. And so the reason I said no to most of the recommendations was because I don't think we need to increase the floor if we're going aspirational on the benchmark. And the exception would be DHS and postpartum care, because we've already set the floor at 3%, which is the highest we usually go. I wouldn't go backwards, but I generally don't feel like we need to go up on the floor if we're going up on benchmarks. So I just wanted to explain that overall concept.
Correct. Thank you very much. Thank you for that input. And as a whole, the feedback is to increase the benchmarks in the qualitative feedback of these agreements, or to decrease the improvement target floors. Yes, Courtney.
Sorry to interrupt. I was going to say Courtney has her hand up.
Oh, thanks. I was just going to kind of agree with Leona and kind of provide an explanation of my feedback too, because I also disagree on a lot of the measures, and it was primarily due to the improvement target floor. And I don't know that, I mean, I think there should still be a floor, but I think it's, you know, pushing to get back to 3% for all of these measures seems lofty, specifically for certain ones that we had intentionally set slightly lower improvement target floors, knowing that, you know, the benchmark is very lofty. So I agree with you, Leona.
Yeah, thank you for reminding us about the interdependence between the benchmarks and improvement target floors. They work together, and there are circumstances in which a higher benchmark and can mean less statewide improvement when the Minnesota method floor is too low. It can be a little tricky and deceiving to have, whereas a lower benchmark and a higher floor can mean a higher level of percentage of improvement across the state. So they are interdependent, and thank you so much for the tool that allows us to see those patterns. Lisa Bowie, welcome.
Hello, it's still morning. Good morning. Lisa Bowie, Quality Improvement Director, Red Lipstick, Red Earrings, Silver Falls behind me. Just in regards to this particular metric, which I know many of y'all have been working on for several years, which I think where the dialogue is going is what does one do with this kind of, I'll call it a fairly innovative metric, which I think y'all know, and how do we wrestle with a metric that's been kind of on kind of out there, but still yet innovative. Courtney mentioned small Ns, or which is small populations for some CCOs, but how do we still kind of work towards improvement when some CCOs have maybe, you know, smaller populations? Now, if you've heard me in Quality Health Outcomes Committee, known as QHOC, where we work on improvement areas with CCOs, you know, some people go, well, even if it's a small one or small twosies, those individuals still need that help. But should it be, you know, how do we focus across the state, because it's a statewide metric, you know, because that's what y'all are charged with doing, and how do we set statewide targets for CCOs that have varying degrees of populations and size? And that's what I think you're wrestling with, and especially for a metric that's been on the measure set for a while. So here's some just thoughts as your quality improvement director. This measure, yes, has been on for a bit. Part of this metric is not necessarily also in its measurement per se. I think this metric is also about system integration. So some of the things that we have grounded ourselves in, this is, you know, I call it BC, which is before COVID, when we did a lot of the what we call peer learning tables around this metric. A lot of what we did was around that system integration, which doesn't compute in the quote numbers or the calculations. And so I think when you're thinking about benchmarking and targeting, the proof in the pudding per se is also in that systems integration. So when you're putting your hats on as CCOs or in your community member hats, also think, where is that improvement coming at, and where are you at in this metrics journey of systems integration as well? And then thinking through, have we not topped out, but where are those individuals receiving that systems integration and care coordinations? That would be my counsel. And if we think we're achieving that, then great. If we think we have some room to go, then push that envelope a little bit more. Hopefully that was helpful.
Yes, thank you, Lisa. Derek?
Yeah, just a couple thoughts I'd like to throw out for the committee. For this specific measure, yes, one of the reasons we haven't gone to the 90th percentile, that wasn't our recommendation, was because of the small denominators at some CCOs. So that was part of the discussion last year, was part of our consideration, certainly in not going a little bit higher. You see that many of our other recommendations were the 90th percentile. So that was in our thoughts. In some ways, yes, I agree. This is probably starting to hit a little bit of a ceiling effect, this particular measure. Right now, this is set for getting all 3 assessments done within 60 days. You might remember that we've had some discussions and we are planning to move forward with, for 2026, doing some adjustments to this measure such that the dental and the physical assessments need to be done within 30 days. And those are actually the federal regulations that DHS is working under. So that would match and align much more with the federal regs. And when we do that, we would need to rebaseline. It would be more around, I think performance right now is more like 65%. If you count it that way, we have been counting it that way all the way along, just so we have that data. But just to know that that's a change that's we're looking at for 26 and likely to happen. And that is what we need to start looking at with some of these measures that have been around for a while, and we're starting to see a little bit of a ceiling effect. Like, what's the next move? Do we tighten the timeline? Do we do other things? What does continuous improvement look like after a number of years with a measure? Or does the measure need to be retired? You know, there's choices that we can, you know, start to make in some of those spaces. I also wanted to speak just a little bit to the process. So we haven't really done you know, presentations of our staff recommendations before the survey goes out on benchmarks, but certainly open to that feedback and open to, you know, sharing a little bit more about what we were thinking kind of on each one of these as we go through this year, and for next year, if we want to change up the order of how we do that, that's certainly something we can kind of consider. I'll speak a little bit to the floors as well. Yes, we were asking for higher floors, or recommending higher floors that the committee consider this year. That wasn't blanket across the slate, though. You didn't see us at 3 percentage point 4 throughout. There was more nuance there. You know, considering 2% on several of them. You know, 2 or 3 percentage point 4s was much more the precedent early in the program and for a number of years until COVID. We do think that is still a valid and needed thing. You know, I think the CCOs that are farthest from the benchmark, yes, the improvement target does become something that's represents enough change and improvement in our minds. But some of those that are fairly close to the benchmark, you know, just getting that 1/10 of the way there doesn't feel like enough of a challenge or a push at times. So that's where we do see this wanting to incentivize the system and be a stretch.
Yes, Leona.
Yeah, I really get that we don't want to reward a 0.1 or 0.01% improvement if the benchmark is not aspirational. But when it's aspirational, if someone is getting that close to it, then, and they're reaching the ceiling effect, that's a win. That's a win for the system. It means that things are working well. And so I think that gets back to the importance of where we set the benchmark. If we set that as truly aspirational, then once regions are reaching that, then we can say, well done. Your system is working well where you are. But if the benchmark's not aspirational, then I agree. The floor is definitely still come into play.
Thank you for all those important considerations as we really jumpstart and the engines on the important considerations in terms of the benchmark and that interdependent relationship with the floors, and consider each measure's trajectory. Very important high-risk population and intention here, a population health intention to quickly assess and address possible health issues in an already at-risk population. Yeah, it does seem that that high percentage might lead us to think that is achieving its ceiling effect. If we just look at the number, the 93, that's a lot. Looking at the distribution across our healthcare entities, the given recommendation of the benchmark at 93.2 and the floor at 3.0, it appears that 3 organizations are at or above the benchmark. However, about 6 of them would need to improve to meet the benchmark, and about 7 of them would need to improve to meet the floor. So we do have like a 3 meaningful subgroups, one that it's already there and is maintenance. These specific recommendations would be keep doing what you're doing. A second group which would be asked to perform higher based on the benchmark just to achieve the benchmark. And a third subgroup with about 7 organizations that would not meet that benchmark, would have to meet the floor. The projection would be that the lowest number would be 72% practically to 91.9%. So just a reminder that there is variability across, and 7 organizations would be asked to just meet the improvement target floor, and another 6 would have to improve higher to meet the benchmark. Yes, Allison.
Yeah, I just wanted to add a little more context behind the staff recommendation. So this benchmark recommendation, the 2022 CCO 75th percentile, is the same benchmark that you chose for 2024 last year, with the 3 percentage point floor as well. Obviously, we don't know the results from 2024 yet. But looking at the 2023 performance, we do know that 2 CCOs would have already met this benchmark with their 2023 performance. We didn't think it was appropriate to raise it again after it had been raised last year. Also of note, the benchmark that we chose last year, this 93.2%, is the first time that the benchmark had ever been raised in the program history. This measure has been included since the very beginning, and the benchmark was set at 90% as just sort of like a committee consensus. It wasn't coming from any percentiles. So we thought that it was appropriate to keep the benchmark the same. One other comment I wanted to make, we can, if the committee would feel it would be helpful, we can share the benchmark selection tool on the screen for everyone to look at. Would people be open to that, or think that would be helpful?
That would be helpful.
All right, thank you, Ashley. I can share my screen then and get that up for everyone to see. You just give me 1 second.
So for the purpose of process and conversation today related to this measure, are we hoping to create a motion and approve each benchmark one at a time? Are we discussing each measure? Is there more discussion on the DHS measure? I guess that's where I'm confused. It seemed like there was general committee consensus on this measure. So I'm wondering if we should try and march forward with some motions.
Based on Jorge's explanation of the structuring, it does sound like we would go measure by measure. And something I should have said earlier, just to reiterate again, is that these are just draft benchmarks, like all the other decisions that you've made the first time around. It is just a draft. So you'll be finalizing these benchmarks in October. So there is still time to think on it and to also receive and review public comment.
Thank you. I would be in favor of voting on the benchmark and improvement target, knowing that it is a draft. And as we discussed fully each of the measures, it might make sense to do it measure by measure, given the important considerations.
Okay, that sounds good.
Thank you. So I would welcome a motion if anybody's willing to make that on this specific measure. Our first
I'll also
measure.
just say I'm having some minor tech issues, but the tool will be up in a second.
That's fine. Thank you very much for making available the tool in the interim, in the survey to prepare us, and in the meeting. It's very helpful. Would anybody be ready to make a motion on the benchmark and improvement target floor for this measure?
I'll make a motion to move forward with the benchmark for the DHS measure at 93.2% with a 3% point floor for 2025. Hopefully I said that right. The OHA recommendation.
I'll second.
A roll call, please.
Okay, let's start with Courtney.
Approve.
Hideo.
Approve.
Stephanie.
Approve.
Lourdes.
Approve.
Leona.
Approve.
Manu.
Approve.
And Jorge.
Approve.
All right, that is unanimous. So the motion passes. You have set the draft benchmark for the ODHS custody measure. And then
Excellent start.
moving on to the next one, we'll go back to the slides just to show you the summary we have about the next measure, and then we can pull up the tool.
Excellent start. Thank you very much. The next measure is timeliness of postpartum care. And staff recommendation is the benchmark of measurement year 2023 with a CCO 90th percentile at 87%. There were 8 committee members who agreed and 1 who disagreed. And again, benchmark, there were concerns or recommendations to increase the benchmark to 90%. I'll open up the floor, comments, questions on the improvement target recommendation for timeliness of postpartum care.
I can just quickly jump in with some explanation behind the staff recommendation, if that would be helpful. So the 2024 benchmark is the 2022 CCO 90th percentile of 85.9%. So this would be a small jump in the benchmark. The 2024 improvement target is also with a 3 percentage point floor. We thought it would be important to stay consistent with the CCO 90th percentile as the benchmark, but just moving it to the more recent year. We also noted that performance did increase from 2022 to 2023. And looking back at 2023 performance, 12 CCOs met the measure, 8 by the benchmark and 4 by the improvement target. So that is kind of how we formulated this recommendation.
Thank you for elaborating on the process for arriving at this specific recommendation. Comments, questions, suggestions? Yes, Courtney?
I'm trying to give everyone enough time before I make a motion. But I'm taking the silence as no one has comments. Is that accurate? Okay, I'm going to make a motion to move forward with OHA's recommendation for the timeliness of postpartum care benchmark at the CCO 90th percentile for measurement year 2023 at 87% with a 3% point floor.
I'll second.
Roll call, please.
All right, let's start with Manu.
I approve.
Jorge,
Approve.
Courtney,
Approve.
Hidea. Hidea, are you there?
Yes, I said approve.
Oh, sorry if I didn't hear you. Stephanie? Stephanie, are you there? Looks like she might have had to step away for a second. Let's go to Lourdes.
Approve.
And Leona.
Approve.
I'll check one more time. Stephanie, are you there and able to vote? Looks like not at this time. However, we would still have a majority with the votes that were recorded. So the motion does pass.
Thank you. This is a challenge pool measure that we just voted and finalized. I would recommend that we consider the challenge pool as a subset after we finalize the quality program first. Would everyone be okay with that? And then go back and consider the 4 measures in the challenge pool in terms of their possibility of having a higher benchmarks and or improvement target floors.
So Jorge, just to make sure I understand what you're proposing, you're saying that you want to have a conversation about separately after we go through the benchmarks, have a conversation, revisit
Correct.
the conversation we've had about maybe setting higher benchmarks for the challenge
Correct.
pool. Okay. Yeah, I'm in favor of having that conversation after we move through voting for these.
Okay, thank you. So let's continue with preventive dental or oral health services. We have 2 age ranges here.
Sorry, Jorge, just to jump in. In the slides, the next 2 measures are the immunization measures. There wasn't really any reasoning for that. They were all voted on in the same way.
That's okay.
We were just potentially giving you guys some more time to
That's
think
fine.
about the preventive dental 6 to 14 age group recommendation, since that wasn't something you had before. Regardless, you can jump to that measure and
That's
that
fine.
benchmark, or you can do the immunization measures.
We can do this. There are all of these measures are ones that received more than 2/3 approval. So that it's fine to continue with this flow as far as I'm concerned. So we have a benchmark recommendation measurement year 2022 at the National Medicaid 75th percentile with 69% for this measure. And a floor improvement target, annual improvement target floor of 3%. And now we get into the subset of measures with 6 individuals who approved and 3 who did not. And one of the recommendations was to increase the benchmark and another one to lower the floor. Questions, discussions? I'll open up the floor.
So I can again give some context to the OHA recommendation. So the 2024 benchmark is the 2020 National Medicaid median, which is 67.9%. So our staff recommendation would be a slight jump in the benchmark. The 2024 improvement target, it has a 1.5 percentage point floor, and we are recommending the 3 percentage point floor. Part of the reasoning why we felt comfortable with this recommendation is knowing that the look back period for this measure only goes back to 2022. And so we think that means that rates should be recovering from the pandemic. However, there was some committee member feedback in the survey that was pushing back on that. So I would welcome any conversation you guys have.
Courtney.
I can start. It looks like Shamiko might have been the other person that provided some commentary around the improvement target floor. not increasing to 3 in addition to myself. So my suggestion was to, either keep it at 1.5 or actually, no, sorry. My suggestion was to improve it to 2 percent point floor. So we're still demonstrating an improvement from the prior year. From my experience working on this measure with local public health departments and providers, there's still an impact lingering from the pandemic, especially around vaccine hesitancy, and improving rates of vaccines has been taking, has not been increasing as much as prior years. And so in response to that and a lot of the feedback that I've heard, I am proposing that we implement a 2% point floor. So we are still demonstrating improvements from the prior year, but not quite reaching that 3% point floor.
Thank you, Courtney. Additional comments, Leona?
Yeah, I have some thoughts, but first I just wanted to clarify, because in the survey, I think it said that the median that we used was 64%, but then in another spot, it said it's 67.9%, or maybe the survey said 67.9, but the tool says 64.
Let me double check that. It might be an error.
Okay. So I don't remember, we're either jumping from 64 to 69 or jumping from 67.9 to 69. Just for reference. But regardless, there's a lot happening in the vaccine space. It's definitely an area we need to lean into and continue to work on. But there's a lot of factors beyond our control, like Oregon allowing really easy non-medical exemptions for vaccines from schools, which means people are moving to Oregon for that reason. And Oregon now has the second highest rate of non-medical exemptions in the whole country. That's not something that CCOs have control over. And yet this measure is to hold CCOs accountable for what CCOs do have control over. So just wanted to point that out. And acknowledge still that even more raises the importance of those one-on-one relationships and building trust and using motivational interviewing and all of those things that we can do in the clinic space. So I'd be fine with moving the benchmark up, but would prefer to keep the floor the same for the reasons that I spoke of earlier.
Thank you. Additional comments, questions about this measures benchmark and annual improvement target floor?
Just to clarify, the 2024 benchmark is 67.9%. Also, I do have the tool ready to go if you guys would like to look at this and see the difference between different floor options.
So we have a proposal to either increase the benchmark and or to lower the floor, correct? What I'm seeing is that with a 69% proposed benchmark, no organization would meet the benchmark. So the improvement target seems to be quite critical, because none of the organizations, entities are close enough to meet the benchmark. Of course, this is based on the projections of it is possible. So they're all the improvement target, as we can see in the screen, becomes really critical in terms of all of the organizations would be their achievement of the measure would depend on the annual percentage improvement target and its floor. With the 69% benchmark, it appears that the the anticipated performance would be from 40% to 64%. And it's virtually not that different with a 2.0 floor. Of course, we would think that there would be an increase somewhere in there, a life or two in the with a higher improvement target floor. Yes, Leona.
Yeah, you made a comment that the floor becomes even more important. I just want to make the point that if the floor stays at 1.5 and we increase the benchmark to 69, 12 of 15 CCOs still have to meet the floor in order to meet an improvement, in order to meet the measure. So you don't need a higher floor in order to continue to push CCOs forward at a time when vaccines are becoming harder and harder.
Correct. Correct. Thank you for the clarification. I was working with recommendation 69%. But yet again, if we change the benchmark, then the implications of the floor are different. Thank you for that clarification. This is a measure with variability. If you scroll down with the supplemental information in where you are, you will see on that third column how those dots right there are spread out. There are some measures in which there's alignment and all the dots kind of cluster. And this is one in which there is quite variability across the state, and hence the projection, if you scroll up, that right there, you stop, there is a 40% to 64% targeted or anticipated range if the organizations were to meet the floor, we still would have a variability between 40 to 64% in this measure. Thank you. So is anybody ready to make a motion? Suggest a higher benchmark, stay with the OHA recommendation, modify the floor? Thank you for the discussion so far. While you think about that, one of the recommendations I have, thank you so much for this important tool and dashboard, is that it would be quite helpful to have a bar that represents the statewide average. So each of these bars is one organization, one managed care entity, and having a different color that it would be, what would be the percentage for the entire state if a particular combination of benchmarks or floors would be important, because what we're here after is not signaling any one organization. So with the respect that there's no names attached here, there's many variables and complexities and important issues that each organization has to face in its own infrastructure and service sector, right? So we're not here to signal out any one single or subset organizations, but we're here to improve statewide level impact and benefits here. So having a statewide average would be quite helpful. And another recommendation would be to have the numbers, the counts, not just the percentages. Because as we can see, when we look at each of these bars and the performance, we do not know whether any specific bar is an organization with 10% of the members in the plan or 40% of the members on the plan. So that movement in 2% in a particular bar means different things. It can mean a lot more people, right, in a large organization. So having the knowledge of how much the number of service contacts, let's say as an example, would increase given the different configurations and benchmarks and floors would be quite helpful. So that's my 2 cents for Dashboard 2.0. If you please consider that. Meanwhile, thank you so much. This is this is much easier than doing the spreadsheeting on the Excel. Thank you. Okay, now that you've had a couple of moments, anybody have a recommendation for us to consider in terms of benchmark or floors?
I think I'll take a stab since no one's gonna jump in. But looks like Courtney was waving to maybe do it, but I'll go ahead and take it. So let's go with the OHA staff recommendation for the benchmark of the 2022 National Medicaid 75th percentile at 69% with a 1.5% percentage point floor.
I'll second your motion. Thank you, Manu.
A roll call, please.
Okay, let's start with Lourdes.
Approve.
Leona,
Approve.
Manu,
Approve.
Jorge,
With the caveat that a 0.5 to 0.9 digit runs up to 2, I approve. Run up, please, to 2.0 in cases in which you need to. Yes, and all mathematical principle. Please round up. Approve.
Courtney,
Approve.
Hidea,
Approve.
and then Stephanie, I believe you're back. Or maybe not. She did message me saying that she had to step away for a minute, but again, with the committee members present, that is unanimous. So the draft benchmark passes for childhood immunization status.
Thank you very much. Excellent progress. Next measure, please.
The next measure is going to be the immunizations for adolescents measure. Just give us 1 second to get the slides back up again.
We are working with the next subset of measures with 6 committee members who approved. That means 2/3 or more, since our denominator is 9, approve of the OHA recommended benchmark and improvement target floor. So immunization for adolescents combo 2. Let's see, which is our next one? Is this the one?
Yes, the last one was childhood immunization.
Okay, thank you. Thank you. Just want to make sure that that's the one. Okay, the measurement year 2022, National Medicaid, 75th percentile as 40.9, can run up to 41. Improvement target of 2 percentage point floors. As stated, 6 agreed. Benchmark should increase relative to recent years. And another comment to lower the floor to 1.5. Any comments on the process to arrive at this OHA recommendation for this measure?
Yeah, so I'll say, looking back at 2024, the benchmark that you guys chose was the 2019 National Medicaid median of a 36.9%. The improvement target was the Minnesota method with a 1.5 percentage point floor. Looking back at the 2023 performance, 4 CCOs met the measure, all by the improvement target. So when we were going through our recommendation, we did feel that it was appropriate to raise the benchmark. However, we did not think it was appropriate to raise the floor all the way up to a 3 percentage point floor, given past performance on this measure. So we are recommending a 2 percentage point floor on this one.
Thank you. Comments, discussion?
I think this would be a pretty similar conversation to the one we just had. And with that being said, and looking at the comments, I would say that leaving it at 1.5% floor would be best.
I agree, Lourdes.
I have the same thought. And just to clarify, it wouldn't be lowering to 1.5. It would be keeping it the same because that's what it is this year as well.
More comments, questions?
I make a motion then, if there's no other comments. I'll motion for immunizations for adolescents combo 2 to accept the OHA recommendation for the bench be based on measurement year 2022 National Medicaid 75th percentile of 2.9%, but to keep the floor at 1.5.
I second.
That was Lourdes seconding, correct?
Yes.
All right, thank you. Okay, let's start with Lourdes then.
Approve.
Courtney.
Approve.
Hidea.
Approve.
Leona.
Approve.
Jorge.
Approve.
Manu.
Approve.
And Stephanie.
Approve.
All right, unanimous amongst committee members present. The motion for the draft benchmark for immunizations for adolescents passes.
Excellent. Thank you very much. Next measure. Next measure in the subset is depression screening and follow-up. And the recommended benchmark is 2023 CCO 90th percentile at 73.8% in a Minnesota method annual percentage improvement of a floor of 3%. There is a recommendation for consideration to increase the benchmark and another one to lower the floor to 2%, lower relative to the recommendation by OHA. Okay, comments, questions, discussion.
All right, so context for the staff recommendation on this one, looking back at 2024, the benchmark is the 2022 CCO 90th percentile of 68.2%, and the improvement target is the Minnesota method with the 2 percentage point floor. If we look at 2023 performance, 15 CCOs met the measure, 11 by the benchmark, and 4 by the improvement target. So going into our recommendation, we felt that it was appropriate to stay consistent with the CCO 90th percentile, but moving it to 2023 from 2022. We also felt that it was appropriate to raise the floor considering the performance on this measure. Performance did increase overall from 2022 to 2023. So that is the context.
Thank you. Comments, questions? Anyone would like to consider increasing the benchmark as stated in the comments? This is another measure with a lot of variability. The projection would be that the performance would be between 40.9 to 72.9, with 2 organizations based on the 2023 data already at the benchmark, and 2 organizations that would whose performance would have to be improved in order to meet the benchmark. And the rest of them would use the improvement target floor that we set up to meet the measure. Yes, Leona?
Yeah, sorry, my internet seems to be getting poor, so I'm going to try keeping my camera off. Sorry for that. Is this a national measure where we have any national data to compare to so that we know how we're doing as a state? I mean, it is a national measure. I just don't know if we have national data.
I would need to check with some other OHA staff on that. Or if anyone else who knows would like to jump in. Oh, there we go. We do not have national data on this measure.
This is an EHR measure, correct?
Yes.
Is there a parallel measure, maybe perhaps at the national level with claims?
Another thing that I want to mention that has been brought up by staff, that this measure's denominator has changed from previous years. In the past, the denominator was members that had never been depressed, and now the denominator is everyone. And it is in the CMS core set, but it sounds like historically so few states have reported it that CMS has never published the results.
Allison, did we look at the impact to that measure spec change on performance?
Let me check with some other staff.
I guess actually, sorry, I think I know the answer to that. We did not because we cannot because it's an EHR based measure, right?
That, yes, exactly.
Sorry. Yeah, I'm interested. I don't know if maybe Leona, from a clinical perspective, could provide some insight on any thoughts on the impact that might have to performance. I know it will increase the denominator size, because historically individuals who have a depression diagnosis were excluded, and that was usually about a large percentage, at least like 40% of the members.
Yeah, that's apologies. I wasn't aware that that change was happening. Is that happening for this year or for 2025?
I feel like it was implemented in 2024, but I know Allison is working hard behind the scenes to find an answer.
I'm being told 2025.
2025? Okay.
Okay. Yeah, because we haven't seen an impact for this year. So that would make more sense that it's occurring for 2025. So it's changing from the prior depression diagnosis to everyone?
Yes, that's correct.
All of our measures in our set have high population health value. This one is behavioral health measure, an important strategic priority for our state. And depression has a really high global burden, global, worldwide, and also national. We're not an exception in the United States or in the state of Oregon, to my knowledge. The prevalence in the population at large is about 1 of 5 individuals at some point experience depression. However, in our OHP population, that's expected to be higher. And I've seen data to the fact that it's higher because of the risk factors associated and stressors, chronic stressors, due to the poverty level qualifications to meet eligibility into the OHP. It's a really important measure. So on the one hand, the measure seems to be one that had a preventive focus, if you will, in terms of detecting individuals who had not previously been identified as having depression. So that it's good from that perspective of let's see, primary prevention, because it's screening. That requires a bit of a measurement work, right? Because you start with the entire population in the denominator and then have to sift through the cases and then identify those that have not, as I believe is the case in the IET. So the measurement burden is higher, but for a good purpose. But now we're switching to just any single individual and screening that it would count into the denominator. I'm sorry, in the in the denominator to start with in the identification process. Yes, Leona.
Yeah, I know that this is just draft, but that might be, I don't know how big of a change that will be, how much of an impact it will have. Would it be okay if we create the draft benchmark on this one at our next meeting in order to think on it and gather some information on what kind of impact that denominator change will have? Because the next meeting, we're also just creating draft, right?
Yes, that is correct. A little more info that I got, providers can submit rebaselining if needed for this measure. It's not always possible, but it is an option. And I think that's everything else I have, unless any other OHA staff have more to add about this measure.
Can you explain that more, what that means that providers can submit for rebaselining?
Yes, just give me 1 second.
Also, well, thanks, Allison, while you're doing that. I just looked at the 2024 specs, and that spec change was implemented for 2024. So I don't know, Leona, if you have some CCO data you can look at, I'll do the same.
Yeah, I might ask if Katie Howard's able to join to talk a little bit about that, but I think our general impression was it might be easier to rebase later if we need to, rather than totally try to predict or guess what it might be in the base, in the benchmarking phase. But it certainly makes sense to pause a month and see if we can gather up some impacts.
Yeah, I think that's a good point, Derek. I was thinking the same thing, that, maybe we can set a draft, whether that's this meeting or next month, but we might need to just have that caveat of like, we might need to reevaluate this after we have the 2024 data submission with the, measuring the impact of this spec change.
The possibility is to postpone this process altogether, or to go ahead and draft with an asterisk that this requires a bit more attention, given the a change in the specifications and the opportunity for a close look at the data, since what we have in front of us is 2023 data in the dashboard, that is. I recommend to move us along to vote on the OSHA recommendation and vote and move motion to set the benchmark at 73.8 and the Minnesota method floor at 3%. Yes, Stephanie?
Can we just move it to next month instead of even voting on the draft? Does it help us to vote on a draft when it might totally change and be more discussion next month? Should we just go to like another metric?
That's consideration for the committee. That's the case for every single measure that's the way I'm looking at it. Thanks for the perspective. We can change the draft next month or October on any of the measures and have renewed discussion.
Saw a thumbs up from Leona. Do any other committee members feel like this discussion should be moved to the next meeting?
Yeah,
yes, I agree. Sorry, Courtney. I also agree.
We don't need to move to vote, but it appears that there's about 3 or 4 individuals that want to postpone this and not even draft it at this point. Okay, let's move on to the next measure. Our next measure is preventive dental or oral health services. So we have recommendations for 2 age periods, 1 to 5 and then 6 to 14 years old. And the first one is the measurement year 2023 CCO 90th percentile, or 60.6%, with a 3% annual increase set at a floor of 3.0. And the committee member feedback is to increase the benchmark or lower the percentage floor. I'd recommend that we consider this first before the 6 to 14, and would welcome the additional observations about this recommendation.
All right, so context on our recommendation. Sorry, Manu, did you want to say something first?
No, please, you first. You're okay. Go ahead.
Okay, so the 2024 benchmark for ages 1 to 5 is the 2022 CCO 75th percentile. That is 52.9%. The 6 to 14 age group benchmark is also the 2022 CCO 75th percentile. That is 61.0%. And the improvement target for both age groups is the Minnesota method with a 1 percentage point floor. Something else that, I do have it on the slide there. I thought I had missed it. We do have it that you must meet both components to achieve the measure. So if, for example, a CCO was to meet the 1 to 5 age group improvement target or benchmark, but not the 6 to 14 age group, they would not pass that measure. We did not have the staff recommendation for the 6 to 14 age group in the survey, but we did go along with what we've done historically in the past, which is to choose the same benchmark for measures that have multiple components. So for our recommendation, we have the 2023 CCO 90th percentile for both the 1 to 5 and the 6 to 14 age group. A little bit of the reasoning behind our recommendations, also with the 3% floor. CCOs are doing very well on this measure. Actually, for ages 1 to 5, 2023 was the first year that the statewide performance rose above pre-pandemic rates. And if we're looking at 2023, all CCOs met the measure, and 15 were by benchmark and 1 was by improvement target. So that is part of why we felt it was appropriate to both raise the benchmark and the improvement target floor. And that is the context for our recommendations.
Thank you very much. We discussed at length the oral health portfolio in our discussions about selecting this measure. We reclassify this as being an upstream measure, right? Because of its prevention value and kindergarten readiness value. Really important decision that we made in terms of continuing to support oral health care in the 1 to 5 year old population.
Thank you, Jorge. I would really like to acknowledge the support of OHA and each and every one of the committee members around us and who are there before us to get us to this level. You know, as everyone knows, there was COVID in 2020 and everything really shut down, and there was a lot of different process controls that inhibited dental providers and CCOs with re-engaging with preventive dental service or oral health service measure. And I'd also like to acknowledge a lot of the support around going in and the integrative component associated with primary care providers, also having the ability to function and steer towards this measure as well. So really kudos to across the entire state for to have the ages 1 to 5 utilization above the pre-COVID or above the before COVID levels of utilization. And similarly, the 6 to 14 is extremely close. It's, I think, within 3 or 4 percentage points. And so while I think for the good of the order, in order to allow for all the CCOs and the dental stakeholders to provide commentary, I believe that the benchmarks that OHA have supported here should be given as draft for both 1 to 5 and 6 to 14. And with that, while OHA is recommending the 3 percentage point floor, as all the CCOs and dental stakeholders have continued to drive for greater and higher levels of aspirational performance, even with having a 1 percentage point floor in years past, I would instead support a 2 percentage point floor instead of the 3 percentage point floor that OHA staff had recommended. So I kind of jumped in their feet first, maybe head first, perhaps. Please share your commentary and thoughts and about everything altogether.
I'll just comment. I'm hearing from our dental groups, they would prefer not to raise that floor. Raising the benchmark feels reasonable, but the floor historically, when it gets to 3%, has been extremely challenging to do in a year. But to Manu's point, this is a draft, and it would give the opportunity for the DCOs to come together like they did last time. That was so helpful to hear their combined or unified voice. So we could set the draft today and then get their feedback in the next two settings of this meeting.
Thank you, Leona. Thanks for jumping in while I try to find my unmute button. Appreciate it. Anyone, please jump in. Other comments, questions? There appears to be variability here in the distribution. Also, this is a measure with two managed care entities that have already met this benchmark, and it would be a sustaining phase, but there's about 4 that would have to improve to meet the benchmark, and the rest would meet the benchmark through the improvement target floor, the annual percentage improvement. There's a comment here about 2.4 points needed in the to impact the CCO furthest from the benchmark. So that's creating a little bit of a threshold here, at least it trigger something in our dashboard to remind us of that. The anticipated improvement would be between 39.8, let's call it 40 to 60%. So there is still variability here across the state. Yes, Stephanie.
I'll ask a question first and then I'll make a comment. So just to make sure I'm in the selection tool right now. And so the way that I thought about the must meet benchmark was that they were going to meet it. If we set the benchmark and the floor, or really just the benchmark, that within a year they're going to meet that, or is it that they have to meet that because of something that I'm missing?
It's not a prediction. It's saying that that's the mark that they need to meet the benchmark. That's what they would be held to.
Oh, okay, because they don't have there is no improvement target for them because they're so close to the actual benchmark that they must meet the benchmark. Okay.
It's not predictive analysis. It's just saying what would be the mark that they would need to hit. What
Got it.
target, either the benchmark or the improvement target or the floor.
Got it. That's helpful. Okay, I just been playing around with the 2 versus 3 for the floor. And there's not I mean, I understand and I'm not on the ground, I'm not a dentist. So there might be a huge thing, a jump in terms of how it really feels. I'm looking at like the numbers and the visuals and it doesn't seem like a huge jump, but again, Manu and others, I lean on you all in terms of like, it's a big jump even just to get to that 3%. I see you shaking your head. Okay. All right. Thank you. That's helpful.
Thank you very much for that reminder about what that means in terms of what would be the anticipated needed performance to meet the measured. And as we consider different combinations of benchmarks and floors, and my mindset went into predictive analysis, which is not necessarily the best language here, but we're trying to anticipate the impact in the recommendation in the policy making decision to set a specific combination of benchmarks and improvement target floors. Thank you very much. But it doesn't seem, again, I'd love to see the entire state level performance percentage associated with this benchmarks and floors, improvement target floors and individuals. In terms of percentages, it does seem to fluctuate very close between 40% to 60% in terms of needed performance across the different organizations, with a 3 or 2% annual percentage floor, improvement floor. Are we ready to recommend to motion.
Yeah, in the nature of time, I'll go ahead and place a motion. And that motion is, darn it. Sorry, Allison, would you mind going back to the previous slide they had up? Thank you. I was going to try to do it from memory, and I just thought, no, that wouldn't work at all. Perfect. So to make the motion first as the draft benchmark for 2025, the ages 1 to 5 benchmark would be looking at the 2023 CCO 90th percentile of 60.6% with an improvement target following the Minnesota method of a 2 percentage points.
Sorry, Manu, I think we lost Ashley for a second.
Okay. Do you want me to start over, or can I just continue with where I was?
You can just continue.
I'm afraid I would recommend take 2.
Nice try, Jorge. Not doing it. It's 11:56. So
take 2. We got 4 minutes.
It'll take me 5 minutes to say. I don't want to hold anyone longer.
You can do it, Manu.
Ages 6 to 14. Measure year 2023 benchmark CCO 90th percentile, 67.3%, and improvement target of the Minnesota method with a 2 percentage point floor.
And would you like to keep the requirement that they must meet both components to achieve the measure?
Yes, that's correct.
I second.
We're so close. Okay. Going through our vote, I'm going to start with Jorge.
I approve.
Manu.
I approve.
Hidea.
I approve.
Stephanie.
Approve.
Lourdes.
Approve.
And Leona.
Approve.
All right, that is unanimous amongst committee members present. You have set the draft benchmarks for the preventive dental or oral health services measure for both the age 1 to 5 and 6 to 14 age groups. And I think
Allison,
oh, sorry, go ahead.
you forgot to call me, but I also approve.
Oh, Courtney, I'm so sorry.
That's okay. I know it passed anyway.
Also, yes.
It's fine, but
starting to fall apart here a bit at the end. We do only have 2 minutes left, so I think that will be our last vote of this meeting.
Thank you very much for the patience with the technical difficulties and recording in and out. It's a good thing that we have amazing colleagues that keep track of our decisions and are going to remind us, believe it or not, recording or not, of what we decided in our summaries, upcoming summaries, in our next meeting with a summary slide of our decisions so far. It is 11:58, then we have 2 minutes. And I'm gonna ask, who's seen that cool OHA new logo with the sun and a mountain? That looks great. There's a saying in Spanish, el sol nace para todos, the sun rises for everyone. So that's a great feeling about our health and healthcare system, right? And there's a beautiful mountain. So you have 1 minute to say which is the Oregon mountain that is closest to you. Oregon mountains, we can do it.
I'll go. I'm in Central Oregon right now, actually, for a leadership retreat, and the closest mountain to me is Mount Bachelor.
Excellent. Anyone else?
I want to say Mount Hood, but it's pretty far.
That's a great guess. It's the tallest one, right? It's testing our geography, right? I don't know if it's Mount Hood or if it's Iron Mountain. It really like going to Iron Mountain and getting to the top, and then you can see the entire Cascades if you're lucky enough on a clear day. I'm afraid it's not the Three Sisters in the picture, right? Because it's one single mountain. In any case, more Oregon mountains is noon.
Given that we are wrapping up the meeting, I am just going to make one more point about the chair and vice chair vote that is happening at the next meeting. So if you are interested in running for either of those positions, please let me know as soon as possible.
And we'll revisit our mountain geography next time. Have a great rest of your Friday afternoon in August, as you wrap up your summer. Thank you for your time and presence. It's really appreciated and valued. Bye, everyone.
Bye, everybody.
Thanks, everyone.
Thank
Bye.
you.
Bye-bye.